Gauri Karur from University of Toronto, Canada. Along with Dr. Prabhakar Rajaya from Mayo Clinic, it is our pleasure to discuss the highlights of our recently published paper on imaging of cardiac fibrosis. Myocardial fibrosis is excessive production and deposition of extracellular matrix proteins that result in pathologic myocardial remodeling. Myocardial fibrosis results in cardiac dysfunction, arrhythmia, and progression to heart failure. Three types of myocardial fibrosis have been described: replacement fibrosis, such as in myocardial infarction; reactive fibrosis, such as remodeling secondary to pressure or volume overload; and infiltrative interstitial fibrosis, that is seen in infiltrative disorders like amyloidosis. Identification and characterization of myocardial fibrosis by imaging aids diagnosis, prognosis, and management in ischemic and non-ischemic cardiomyopathies. Several non-invasive cardiac imaging modalities directly or indirectly depict myocardial fibrosis, and we'll talk about each of these. First and foremost is echocardiography. Echo is widely available. This does not directly visualize or characterize scar. It's also dependent on the acoustic windows as well as the operator. Various techniques are available, among which dobutamine stress imaging is used for viability assessment. Next, we have the nuclear medicine techniques. Thallium scintigraphy is used for scar assessment. FDG PET with perfusion imaging is used for assessment of viability. Both of these techniques have lower spatial resolution compared to MRI. FAPI PET is an emerging technique that is used for assessment of fibrosis. Next is CT. CT is often used when MRI is contraindicated. Late iodine enhancement can be performed. This has low contrast to noise ratio but can be improved with the use of dual energy techniques. Extracellular volume measurement can also be performed with CT. Our paper focuses mainly on MRI. Among the various MRI techniques, LGE permits direct visualization of scar. Parametric mapping using T1 and ECV help in qualitative assessment as well as quantification of fibrosis. This can be particularly valuable in the assessment of diffuse diseases, cardiomyopathies which do not have LGE, for prognosis, risk stratification, and for monitoring therapy. It is important to have local reference ranges for comparison. MR fingerprinting, radiomics, and texture analysis are non-contrast and emerging techniques. Dobutamine stress imaging is used for viability assessment. However, this requires a lot of expertise. This is an example of a 62-year-old male with Fabry's disease. The short axis LGE image shows subepicardial LGE. This is the T1 map, and the orange ROI that is drawn in the septum shows low native T1, which is indicating glycosphingolipid deposition. Elevated native T1 as well as elevated extracellular volume in the infralateral wall with the presence of LGE are all indicative of fibrosis. A common indication for imaging in the context of myocardial infarction is to determine myocardial viability. On MRI, stunned myocardium or hibernating myocardium show contractile dysfunction without any LGE, whereas infarcted myocardium shows contractile dysfunction with the presence of subendocardial or transmural LGE. This is an example of a 57-year-old man with recent myocardial infarction. There is transmural LGE in the inferior wall along with the presence of intramyocardial hypointensity, which is suggestive of microvascular obstruction. Scar significantly increases the risk of sudden cardiac death in cardiomyopathies, and this is incremental to traditional risk factors such as ejection fraction. Pre-ablation MRI is used to define scar location and extent. This can facilitate electroanatomic mapping during the procedure, decrease the procedural times, and improve the procedural outcomes. This is an example of a 43-year-old male with ventricular tachycardia. Short axis MRI LG images show scar in the lateral wall of the left ventricle, and this is predominantly epicardial in location. Image from electrophysiology study confirms the location of epicardial scar. VT ablation was performed and the red circles depict ablated lesions. Ablation successfully eliminated ventricular tachycardia in this patient. Establishing the diagnosis and etiology of cardiomyopathy. Various LG patterns are described and these are associated with specific etiologies. For example, subendocardial or transmural LGE in a conforming to a vascular or coronary territory would be indicative of myocardial infarction as seen in this first imaging example. Mid-myocardial or linear LGE, as seen in the second example, can be seen in entities like idiopathic dilated cardiomyopathy and myocarditis. Mid-myocardial patchy LG at the RV insertion points can be seen with hypertrophic cardiomyopathy, such as in this last example. Multiple other LG patterns and etiologies are described in this table. LGE is the primary endpoint in current management models predicting risk of life-threatening cardiac arrhythmias. In ischemic cardiomyopathy, LG is associated with a lack of response to medical therapy and requirement for cardiac resynchronization therapy. In non-ischemic cardiomyopathy, LG predicts heart failure, hospitalizations, sudden cardiac death, and mortality. Elevated native T1 and ECV also predict adverse cardiovascular outcomes with potential additional prognostic utility beyond LGE. This is an example of concentric hypertrophic cardiomyopathy associated with an extensive scar burden, which can be accurately quantified using MRI. MRI plays an important role in guiding treatment strategies, assessing treatment response, and monitoring disease progression. This is an example of a 39-year-old man with cardiac sarcoidosis. The first two images were acquired during the active phase of disease. Axial FDG PET MRI shows diffuse FDG uptake. Short axis MRI LG image shows marked mid-wall as well as subepicardial LG involving multiple myocardial segments. Findings are suggestive of myocardial infiltration and inflammation. Follow-up imaging performed after 5 months of prednisolone therapy shows no FDG activity and there has been reduction of LGE. Mild residual LGE suggests infiltrative interstitial fibrosis. So in conclusion, LGE imaging by cardiac MRI plays a pivotal role in the diagnosis of cardiomyopathies and risk stratification. Cardiac MRI parametric mapping techniques allow visualization and quantification of diffuse myocardial changes from both intracellular as well as extracellular processes. Native T1 and extracellular volume measurements help monitor the myocardial response to drug therapy and provide a surrogate endpoint in novel drug therapy trials. Thank you very much for your attention.